Thank you, and thank you for the invitation to this symposium. As it has been told, I'm from the Danish Veterans Center, and I'm going to talk about the efforts regarding veterans and the work that we do with a focus on suicide or prevention of it among the veterans. So I will give a short introduction to the Danish Veterans Center, and then due to I've been told that there are some I also should come with some practical aspects. I will talk about practical experience and prevention of suicide. And at last, I will show some results from two recent publications that we have made, two papers regarding suicidality among veterans. Well, Denmark started out a little late, not completely prepared for the Balkan veterans who was deployed in the 1990s. But since the veteran policy was introduced in 2010, the effort progressed in high speed. And the services of the Veteran Center are provided to all veterans by this definition, which is a person who alone or part of a unit has been deployed at least in one international mission. The person may still be serving, but can also be discharged and either being part of the civilian labor market or back in school. The first Danish veteran policy was introduced in 2010. Prior to the policy, the efforts regarding veterans has been limited and ad hoc based. So when it started in 2011, it was from scratch, and it has been developed since. Due to the definition, persons who participated in national operations in Denmark are not entitled of any of the services of the Veteran Center as it is today. The Veteran Center has approximately 140 persons located all over the country. The employees are mainly within the area of science and research, treatment and support and counseling. As I said, the Veteran Center covers the whole Commonwealth of Denmark, and it is mainly located in barracks, but also aviation and naval military facilities. The Veteran Center cannot be compared, or the veterans cannot be compared, and they are not all the same. This is why we offer a number of services that can be adjusted to the individual of the veteran. And our research ensures that offers are what they need. All it takes to acquire our services is either a phone call to our hotline or make contact with an employee around the country. A commander can also reach out if he has concerns. And here the Veteran Center offers to contact the veteran or discuss the best way ahead with the commander. We have a department within psychology where we have treatment, and we use treatment which have scientific proof of working against fear and depression, but also against PTSD. The three methods used most frequently against PTSD are exposure therapy, group therapy, and couples therapy. Evaluations indicate that most veterans suffering from PTSD feel better after undertaking regular cognitive treatment, approximately 60%. However, some veterans feel no effect, so we are trying alternative methods to treatment that can be body therapy, virtual reality, or EEG treatment. So we have different solutions. We deal in psychological post-reactions, but also with numerous side effects veterans suffers from having been deployed for a longer period of time. Our services are meant to be one size does not fit all, but instead tailored to fit the needs of each individual veterans. So if you need a service stock, we can provide that. Others have others priorities or needs. We have research, which is where I'm from. We have 4 main areas: treatment, screening, prevention, and reintegration. Honoring the veterans is just as important as preventing and treatment, and honoring the veterans is done by initiatives and events such as medals. We have flag days, veteran cards that give you discount several places. And then we have an official monument in Copenhagen, which is where the picture is from. So the Veteran Center is involved before, during, and after deployment. And there's cooperation with units, commanders, soldiers, and relatives. All of our efforts can be said to prevent suicide, because if you have the preparation before the deployment, it would also give you a smaller risk to have psychological reactions after your deployment. So to get a better picture of the Veteran Center effort, I will try to give an example of a case, so it also gets a little practical. This is, we can call the veteran Peter. Peter has been deployed to Iraq, the Balkans, and Afghanistan. He has been diagnosed with complex PTSD in 2020. Peter doesn't work anymore, but are on early retirement. Before he entered the army, he was a spontaneous sportsman. Peter is isolated in his home. He has alcohol abuse. He has no close relations. He has identity crisis, anxiety, and insomnia with sleeping problems. Peter is isolated in his home. He has drinking problem, especially in nights. And this is where the thoughts about suicide comes to his mind. When he has these thoughts, he calls the Veteran Center hotline, where he can talk with either social workers or psychologists about his problems. Because of his many dials to the hotline, the Veteran Center has offered Peter to come in contact with a social worker that can help him. The social worker has visited Peter in his own home, and they get the relationship growing. During these visits and conversations, Peter gets informed about the many options that the Veteran Center and the volunteers offers. This is supporting activities and events that Peter didn't know about before. In the period from 2019 to 2022, the following has happened for him. He starts in treatment for his alcohol abuse in the municipality where he lives. He starts up training again under the auspices of so-called safe zones, which are local sports facilities for injured veterans, physically as well as mentally. Peter starts psychological treatment within the Veteran Center, Department of Psychology. He starts financial counseling offered by the volunteers, and Peter gets to treat in 6 months at a specialized veteran camp where he can live. So today, Peter is no longer having alcohol abuse. He lives at residential facilities for veterans. He has control over his financial situation, and he trains every day and has get a great weight loss and better energy. He's positive about his situation and the possibilities it brings him. He still have contact to a social worker because the counseling and all other offers in the Veteran Center is lifelong. So he can also always return to the center. Peter is not suicidal anymore, and he has got his life back. So this is an example of how it's practical is when the Veteran Center works together with all the volunteers within the area. So the story about Peter was just one out of almost 40,000 that each veteran can tell. Every veteran is unique, but there are some general facts that I can list here. So we have about 40,000 veterans registered in Denmark, and they have been deployed for more than one time. They've been deployed in all about 114,000 times. Approximately 1 out of 10 veterans has symptoms of depression or PTSD. And this is symptoms. If we talk about who has the PTSD diagnosis, it's a smaller amount. Several veterans experience that PTSD symptoms occur more than 7 months after ending the deployment. Some of them that can go several years before they get the PTSD. Treatment of PTSD reduces the symptoms for approximately 60% of them. 0.2% of our veterans are homeless persons, and that's like every other group in Denmark. There are some who are homeless. The 90% of all the veterans are having a job after they have been deployed. So to give a picture of how the suicidal is all over Denmark, there's some facts here. In 1980, in Denmark, there was the second highest suicide rate worldwide, and we had 1,600 suicides per year. This was very high, and there has been a lot of prevention work since then. And since 2007, the suicide rate has fallen and is one of the lowest worldwide now. And we have around 600 suicides per year. So how is it with suicidal behavior among the Danish veterans? From December 2018, there has been 75 deaths by suicide among veterans, and that is 0.2% of all the veterans. And to give that in a setting, in 2018, there was 584 persons in Denmark who died from suicide. 2 of them was veterans. So the rate of suicide among all veterans in Denmark does not differ from the background population, and we don't see it as a large problem among the veterans. However, the Balkan veterans from Croatia back in 1990s has higher risk of death from suicide compared to other veterans. That could be due to the fact that back then there was no veteran center, there was not the same follow-up on the veterans. But now we don't see many veterans who die from suicide. We have been doing some research about what is stressful and what is protective for suicide among veterans. There have been some Danish reports, and we have also done scientific articles. But what we have identified has been factors that are stressful for suicide is that if you have suicidal behavior before the deployment, then you have higher risk also afterwards. And similar, if you have psychiatric diagnosis, if you feel powerlessness during your deployment, and also if you come home and you feel guilt and shame of what you have been doing or what you have been seeing, then you have a higher risk for suicide. In Denmark, we are working with the guilt and shame, and we are in the middle of making a moral injury questionnaire. So that's a work that we are doing at the moment. Some factors that have been shown to be protective is family, that you have the family support, and also that you have children who is always called that they need that you are there. Also, social support and recognition has been found to be protective. So we have some recent publications from 2 scientific papers that we have been doing. One is about combat exposure and risk of suicide attempts among the Danish Army military personnel. So that is attempt. And then we have been doing a pooled analysis of the all-cause and cause-specific mortality among Danish and also other Nordic veterans, where we see who has actually died from suicide. Before telling about the studies, I will briefly talk about data, because in Denmark, and especially the registered data. In Denmark, we are so lucky to have all these registers, and the population-based studies has advantages. In Denmark, we have the whole population for registered research, and the whole population is of 5.8 million individuals, which we can have data from. Denmark has an extensive public healthcare system that offers free consultation and treatment at a local doctors, emergency wards, and public hospitals. If you work in Denmark, you're also covered by the Danish health insurance system, and most examinations and treatments are free because of this national healthcare that is funded through taxes, and it covers 100% of the population. The only thing you must do is to register and get a health insurance card. And this is also how we then can link all the visits at the doctors or the hospitals in these registers. And it's all the what's combine all these things is the personal identification number. We also have data from the Danish Defense, where we have what we call a deployment database with military personnel from 1992, and at the moment it is to 2018, but we have updated it. So here from January we have 2022 also in the database. We have this identification number, name, mission, function, etc. So we can link this to the registers. We have around 30,000, a little less, a little more in this database, and they have been deployed around 2 times each. Then we have our questionnaire data. In the Veteran Center, since 1998, we have been following the veterans when they're coming home. So 6 months after homecoming, they get a questionnaire with the question is called the psychological reactions after international missions. And we have data from 21,000 missions from 14 unique persons. There's questions about under deployment, what was your military rank, what have you been exposed to, combat exposure, social support, how was the leadership, things like that. Then there are questions about after, when you came home, was it difficult to come home, what is your well-being, social support, and things like that. And also, have you had thoughts of suicide or suicidal behavior? If you tick yes, I have suicide behavior, then you are contacted by a psychologist within the center that ring you up by the phone and offers you to come and get a treatment. We also in the questionnaire ask about symptoms the last 3 months, which are depression, arousal, dissociation, all sorts of things. And we have the measure for PTSD and also for depression. So we also get a lot of data in this, and there, as I said, there's 2 parts of this. We can use it for research, but also to identify those who may need help. Then we have some special ISAF teams, ISAF 7, 10, and 15, that have been, they have got several questionnaires. The ISAF 7 have got 7 times they have been invited to answer these questionnaires before they got deployed, under the deployment, and then afterwards. And they have been, the latest was 6.5 years after homecoming. So we have a lot of data of these special teams as well. So given that we have all these data, it gives us a lot of possibilities to do the research and can do it with different kind of data. In paper 1, which is combat exposure and risk of suicide attempt, we have included 12,000 soldiers who was deployed during 1996 to 2009, and 83 soldiers had a suicide attempt after homecoming. And this was the suicide attempt was those we could see in the registers, so they have been at the hospital. So we combined these questionnaire data with register data for the contact to hospitals due to suicide attempt. So we looked at combat exposure, and we had two different kinds of combat exposure. We were looking at who has been directly, and I can see some of this is in Danish, sorry. But the combat exposure was directly, it's being threatened at by weapon if somebody has been shooting at you or have been in other danger areas. And then we had the consequences of war, which is more, it's not the directly combat exposure. And the outcome was suicide attempt. So the results was that seeing the consequences of war, there was no significant association to suicide attempt afterwards. But the directly combat exposure, we found that there was an association with suicide attempt. But when we did the analyze, we found that the association between combat exposure and suicide attempt was explained so totally by the PTSD and or depression symptoms. But what also was interesting to find was that the social support during and after deployment, as well as psychiatric diagnosis before deployment, was also significant associated with later suicide attempt. And these two variables are, that is something that we can do about. We can't do anything about their age or their gender, but social support is something that we can work with. So the other study was all-cause and cause-specific mortality among Nordic military veterans following international deployment. This was a Nordic collaboration between Denmark, Norway, Sweden, and Finland. And Nordic health data has the same infrastructure which is similar. And it's a gold mine for the register-based research. So the purpose was that, one, it's rare outcome. We don't have that many veterans that are dead, and especially not when we look at different reasons why they die. So bringing all the Nordic countries together, we have a larger data. So also it was to find if there were some signals of concerns. So also something that we should be following close in each country. So what we found was here we have in the top, it's a full period from the study period, and then we were looking at what are some differences in the first 5 years from homecoming, and then 5 years or more after. But what we found is that all of the countries, Denmark, Finland, Norway, and Sweden, the veterans has a lower all-cause mortality, and also the red dot is when you pool the country together. So they have, as we also expected, they have a lower risk of dying than the background population. When we look at external causes, also if you just look at the top, they also have a lower risk of 0.7. Then we looked at suicide, and there you can see when we pool all of the Nordic countries together, there's a risk of 0.77, meaning that they have a 23% lower risk of dying from suicide than the background population. The risk was not significant for Denmark, but the other country it was. So in the other countries have a significant lower risk, but in Denmark it's on the same level as the background population. And we were also looking at traffic accidents, and also sometimes it can be difficult to see, is this when somebody have been driving in their car directly to a tree, is this then a suicide or is it a transport accident? Therefore, we wanted to look at how was the data on this also. And we see when we look at the transport accidents, there's not a significant lower risk. It's on the same level as the background population. So what I think is a take-home message from this is that the Danish Veterans Center offers treatment, counseling, and support, research, and honoring of the veterans. Not all our veterans are equal, and therefore we have the one size does not fit all. We try to do the support so that every veteran gets something out of it. Among the Danish veterans, overall there are not many who die from suicide, but the veterans deployed to the Balkans in the 1990s, there was a higher risk of suicide. So, thanks for the attention, and then we have some time for questions.
Yes, it's time for some questions. I think it's very important what you do. I guess it's safe to say that when people come to safety from war, it does not necessarily mean that the war has ended. So I think it's very important that you care for that. And we have some related questions. One is coming from the army myself, I know that veterans look with a lack of trust towards psychologists who have no combat experience. It's harder to build a mutual trust. Do you find such an issue while working with veterans in Denmark?
Yeah, I can see what you mean. We have some who, when they have been deployed, they say no more defense, no more, and they don't want to go to the military stations to visit a psychologist. So we also work together with what we call network psychologists, so that you can get the treatment outside the defense, but still it's paid by the defense, but you don't have to get one who is within the defense. That's one part of it, and the other part is that we also experience some who come and say that you don't understand how it was, you don't get it, and our psychologists they try to get them better to learn and to have I can't remember the word, to get that trust, so they come and visit. When they are deployed, they come and visit. For example, in Afghanistan, they are away 6 months. When they have been there 2 months, then they are coming 2 psychologists down to the deployment area, and they are there for 3 days, and everyone can come and talk to them if they feel like. So they try to somehow, they haven't been deployed like a soldier, but they have been in the area and they know how the setting is. Yeah.
Okay, so being acquainted with a person it helps. It may help.
Yeah.
Okay. We have another question. How do you work with veterans' guilt and shame when there is an actual reason to experience these feelings?
Yeah, of course, the psychologists have such a program where they can identify it. Is it if they have PTSD, for example, is it because of guilt or is it because of something else? So they can screen in some way. But as I said, we are in the middle to have to work with this questionnaire which is going to identify the moral injury, which is if you have the guilt and shame and you feel you have been witnessing something moral wrong, or you have been forced to do something that you really didn't like. So we are in the middle of that, and also we have cooperation with the Danish church, the priestess. That we also have priestess within the defense that also come and visit during the deployment, and they are good. They can something else, because that's exactly the question about the guilt, that they can help with in another way than the psychologist can. I don't know if that's clear.
As I understand, you have multiple resources available for veteran, and you are working on something more specific. You mentioned like moral guilt. Yeah, you are working something in that direction.
Yeah.
Could you maybe tell a couple of words about that? It's very interesting.
Yeah. The questionnaire it's called the MIOS, MIOS. It's moral injury, and I can't remember what the O and S is for. But it has been developed by researchers by UK, the United States, Canada, and Australia. And they have just been publishing the first finding where they have used this questionnaire in a military setting also. And Denmark we are now getting involved in this working group so that we also can try to use it within the Danish veterans and get data on this. And then when we have the first data, then we can try to discuss what are we going to do about this, because it's not enough just to have a questionnaire and to identify that some are having moral injury or moral problems. Then we're going to talk about what's next, what are we going to do with it, how are we going to deal with it, because it's not enough just to have identified that they are having these problems. So there's a discussion about, should it be a diagnosis that you can have? Also, you can have PTSD, you get a diagnosis, you can have a treatment program. Should you also have some kind of diagnosis for the moral injury? And how do we then treat this? What should we do? So that's some of the work that we are in the middle of at the moment.
We have a couple of more questions. We may have time for that. Thank you for your good practice. Did you mean a suicide rate drop in Danish veterans or in general society? If generally, how did you reach such a significant progress?
Yeah, it is in the general population that back in the 1980s, it was the second highest worldwide. And now, since 2007, we are among the lowest. So there has been a lot of focus on that. There has been some effective preventive programs. That has been, I try to find the words. In Denmark, in the 80s, you could buy a large glass of pills against a headache, for example. And now the packaging is that you can only buy 10 when you get in the store. So in that way, you can't just get a whole amount at one moment. Then we have also got some national counseling on the phone. And then there has been some at the hospitals for the psychiatric patients. There have been more safety in the rooms also. So it has been targeting in many ways to get the rate fallen.
Yeah, that's really really an impressive drop, which you showed.
Yeah.
The last question would sound like this: what kind of scenarios do you use in VR treatment? I think you mentioned.
Yeah. Is it like the scenarios that they see in the screen?
Yeah, I guess it's about virtual reality. Yeah.
Yeah, it's in the psychological department. They have this VR. It has been on a project, and it is not something that we can offer all the veterans. So it is as a project. But when they get the screen on, they see it's like exposure therapy. It's like being back to, for example, Afghanistan. Mm-hmm. And then there are also some I don't know what it's called. It's so when you are in the room, then they can have some smell, so that it also smells like the dust when you walk on the mission. And there's also the sounds had been recorded, so it's like coming back to where you have been deployed, and it is the exposure of this.
So you kind of use creative ways for the exposure to remind of the scenes.
Yeah.
Okay. I see that we have a couple of minutes left. May I ask one question? You mentioned a bit about differences between veterans in general and veterans who served in Balkans. If I'm correct, you mentioned that it may be related to the fact that the help was not there was no so much help options. Could it be something related to the experience itself during that deployment?
In the 90s, where we started sending military personnel from Denmark to these kind of operations, it was earlier missions has been like a holiday at Kibon and such places. And when they got to the Balkans, they were not prepared. They didn't know what they were coming to, and they didn't have the way that they were deployed was that they were not able to do something. They were on a UN mandate, so they didn't have. They could just stand and look at all those horrible things that was happening. So I think one of the reasons could be that also.
Because of that experience itself, the horrible experience.
Yeah. And the fact that they weren't prepared for it.
Really, thank you, Mia, for your knowledge, for the way you presented it and you shared with us. I hope that we will see each other more. And now I say you goodbye. And to everyone,